Hi and welcome. I'm glad you're here. If you're listening to replay, I hope your week is going well. I'm Dr. Kara Pepper, and today I want to talk about Ehlers-Danlos Syndrome, a supposed zebra in the field of medicine, but actually not as uncommon as I was taught in med school. And I want to talk about how we even go about making a diagnosis, because this is probably the primary challenge that a lot of my patients face. I'm an internist in Atlanta, Georgia. I was not trained as an Ehlers-Danlos doctor. I was trained as someone who knew how to manage heart failure and patients in the ICU and chronic diseases like diabetes, but no one really talked to us about connective tissue disease outside of lupus and rheumatoid arthritis. And so I didn't get a lot of training in this. I am, however, an eating disorder doctor, and it was very clear to me that my patients never, quote, just had an eating disorder. And so I found my way into this work because there's a high degree of overlap. I'm in Atlanta, Georgia, and see folks in 17 states. But if you're here local to Georgia, come see me. This is literally my office where I'm recording. See that picture in the back. A reminder that I am a doctor, not necessarily your doctor. This is for information and not diagnostic purposes for you specifically. Talk to your team. Patients eternally are my greatest teacher. Yes, in medicine, we learn the guidelines, we learn lots of physiology, we learn root causes, but much like artists, we learn the technique, but it's the application of that information that really makes us who we are. And it was clear to me I did not learn everything I needed to learn. There was no way to do that in med school or residency. And so I continue to learn every day from my patients. And like I said, patients would come to me saying, hey, I've got all these symptoms and either I want a diagnosis because I think I have this problem, or no one seems to know what's going on with me. I've seen 1,000 people. And so that's led me to get super curious and get connected with folks who are taking care of EDS patients. And I've learned a tremendous amount, which I will talk about shortly. So Ehlers-Danlos is a form of connective tissue disease, meaning all the glue that holds our body parts together, our joints, our ligaments, our muscles, but all the tissue in between that surrounds blood vessels, that surrounds nerves, that surrounds organs, it is impacted. And there's largely a number of genetic mutations that cause this disease. And there's a lot of people who are really smart at Ehlers-Danlos. So I point to them repeatedly through this presentation. But our latest guidelines on how you even describe EDS and diagnose EDS came from 2017. A big group of folks put together what we now have as our clinical criteria. There are 13 different subtypes of EDS. As you can see, the most common is this hypermobile EDS, one in like 3,000, so not that uncommon. But as we start going down into the classical or the vascular, which is what a lot of people worry about, a little less common, one in 20,000, one in 200,000. But then the rest of the 13 subtypes are literally 1 in a million or less than 1 in a million. Now, someone is that 1 in a million, right? But in terms of general clinicians who are seeing these folks, we may not see a lot of these folks in our career, if any, but you will absolutely see the 3 most common types, the hypermobile, classic, and vascular, in your career. And so all of those 13 subtypes have genetic mutations, which you can test for. It's a very simple blood test. LabCorp literally is called the Ehlers-Danlos panel, and it will look for these genetic mutations. In terms of cost, geez, healthcare in America is really expensive, but what I've heard anecdotally from patients is that the test runs between $250 and $750. Who knows if it's more than that on your particular policy. And then there are third-party companies that are coming into the marketplace allowing patients to self-test, and those are around $500. It's important to note that the most common form of EDS, the hypermobile EDS, there is not a genetic mutation. So we call that a clinical diagnosis, meaning there are specific questions that your doctor should be asking you. There's clinical criteria, which I'll get into in a minute. And you should be able to look at those clinical criteria with your doctor and be able to discern if you have this diagnosis. Easier said than done. So what I was taught in med school is EDS is genetic. There's nothing you can do about it. So don't even bother testing your patients. Who would want that kind of diagnosis? And in fact, I had a patient last week come to me and say, hey, no one will test me because they said there's nothing that we can do about EDS. I will really push back on that. I think the breast cancer gene is widely screened for in our communities. And if you know that you have a genetic mutation that increases your risk for breast cancer, there are things that we would do about that. We would increase your screening, we would increase your support, we would give you counseling. Yes, you cannot change the genetic condition, but there are definitely things that you can do about that. And so that is my opinion about EDS. If someone with lifelong symptoms is coming to me wanting an explanation, I would not hesitate to diagnose them with something like diabetes or heart failure. So this should be no different. And then secondly, to have validation for, yes, there's a name for all these symptoms I've had through my entire life, I think is really helpful. I had a patient ask me yesterday, well, what is that going to mean in terms of insurance? Insurance is really labile. Our healthcare industry is crumbling. So if I have this diagnosis on my record, does that mean that I will, be barred from insurance in the future? And the truth is, I don't know the answer to that. I really don't. There was a period of time where we had the luxury, the right, as I would call it, to be afforded healthcare insurance without pre-existing conditions. That may change. So I don't know the answer to that. But what I do know is that my patients deserve to have a diagnosis and a treatment plan. And although I cannot change their genetics, I can offer treatment services, including physical therapy, including screening for other comorbid conditions that can help people feel better. So if you've seen one patient with EDS, you've seen exactly one patient with EDS. Even in the most common types that we talked about, the classic, the vascular, and they mentioned kyphotic here, the symptoms can be overlapping. I will screen us back to this article, which I'll put a link for in the show notes. The citation is here. They go through beautifully looking at all the 13 different subtypes of EDS, the clinical presentation, the symptoms, and the things we'd find on physical exam that really differentiate those. But not all of them are their own distinct clinical subset. There is a lot of overlap in those symptoms. So generally, the treatment modalities have a lot of similarities, but there are things that make those specific to each diagnosis, besides just the genes themselves. So like I mentioned, if you don't have the genetic testing helps you differentiate the 12 of the subtypes, but the hypermobile subtype does not have a gene test that goes with it. It is a clinical diagnosis. And with that article that came out in 2017, these criteria were made into a handout, which is readily available online. I will gladly put it in the show notes as well. But I'd like to go through that when we say it's a clinical diagnosis. These are things that any clinician should be able to do, and you can actually do on yourself. Oh, pause, please, while I pull up that form real quick, because we'll go through it together. All right, I think y'all can see this. Okay, here we go. So this is that form, it's scrollable. So I will start out by saying that it is imperfect. There are plenty of people who very clearly meet criteria for EDS who do not, quote, pass criteria on this form, and I'll talk about that in a minute. But in short, there are 3 different criteria categories. The first looks at general joint hypermobility. The second looks outside of joints and looks at family history, and you have to, of these 1, 2, 3, A, B, C subtypes, you need at least 2 of these categories to be considered positive for criteria 2. And then lastly, there's criteria 3, which looks at basically excluding other diseases that might cause some of those symptoms. So let's start at the top. Quite infamously, they start by saying, children tend to be more hypermobile than adults. So the threshold to meet these criteria gets lower as we get older because adults get stiffer with time. But the Baton criteria is kind of infamous or famously associated with EDS. And that is these 5 maneuvers here. So the first is to look, if you put your hand on a flat surface and extend your pinky finger back, does it go past 90 degrees? So you get 1 point for each hand. So that's 1, 2. The second is if you fold your hand forward and you pull your thumb back towards your wrist. If the thumb touches your wrist, that's another point. So you get 1 point for each side, 1, 2, 3, 4. The third is elbows hyperextending past 10 degrees. So if the elbows go, you get 1 point for each side. And then you get 2 points for each point for each knee. So if you turn sideways and the knees hyperextend backwards, they're not up and down in a straight line, but they hyperextend. It's a point for each knee. And then the last is with straight legs. Can you bend forward and put your hands flat on the floor? So it's 2, 4, 6, 8, and then 1 point for your hamstrings. That's 9. So if women for men or women over the age of 50, if you get 4 points, that's a positive Beighton score. For young adults up to age 50, you have to have 5, and for children pre-puberty, you have to have 6 criteria. I do appreciate that they ask specific things. They ask again about the Beighton criteria, but did they ask, can you amuse your friends by contorting your body into strange shapes or do the splits when you were younger? And my way of asking patients is like, did you have party tricks when you were a kid? So clearly this is just like hands and elbows and knees. It doesn't really get to significant hypermobility. I have patients who don't pass this, but they're like, yeah, my shoulder dislocates on a regular basis, or my ribs pop out of place, or my patella popped out of place. That's one of the limitations of this test, is that it doesn't fully capture all of the different ways that people's joints are hypermobile. But I think this is their nod towards that to say, could you contort yourself into strange shapes? Do you consider yourself double jointed? So if you meet these criteria, do you meet at least 2 of these down here? So that's 1. So that's criteria 1. And then the criteria 2 looks at other things outside of joints. So it looks at skin specifically, unusually soft or velvety skin. It's got a very specific kind of texture. It feels exactly like that, velvety. I like the way that they describe it. Do you have mild skin hyperextensibility, which I'll show you some pictures in a minute. But that's effectively, if you take the palmar aspect of your arm, the forearm that's proximal to that, if you pinch the skin and it's able to stretch out at least 1.5 centimeters, that's considered hyperextensibility. I certainly have people who are able to like pull their skin out in very dramatic ways, but at a bare minimum, it should be 1.5 centimeters. Do you have specific stretch marks? Striae is the word for stretch marks. On the back, groins, thighs, breasts, and abdomen, which many without the history of significant gain or loss of body fat. So do you have kind of unexplained stretch marks? And some of the places that I like to look for those are on places that people don't really stretch. Does it happen on someone's spine up and down? So like on your lower back, you should, people don't grow a lot in their lower back. So if they have unusual stretch marks there, it's a place I like to look. Does it happen further down on the arms? Does it happen on the calves? I had a patient recently who had stretch marks on their calves with very small calf musculature. So do you get unexplained stretch marks outside of weight gain? The next is pysogenic papules, which I'll show you a picture in a minute, but basically the connective tissue around your heel is a little loose and some of the fat sticks out. So people get these little yellow nodules. Atrophic scarring, again, I'll show you a picture of that in a minute, but you have these very specific scars that have this kind of like loose appearance to them that after healing. Dental crowding, so not just did you wear braces when you were a kid, but is there very specific like overlapping of the teeth, or is the palate, the roof of your mouth, quite high? Arm span to height ratio, basically, are you wider than you are tall? So it's a sense that the arms have stretched really wide. And then mitral valve prolapse, which you can only see on an echo. Ultrasound of the heart. Does part of the heart valve, the mitral valve, does it flop back into the atrium? So you need an echo in order to see that. And the aortic root dilation, you'd also need an ultrasound or other cardiac imaging to pick that up. And is it enlarged? So it's a lot of physical exam stuff, but that is done in the clinic where someone would examine you. And so they want to see, did you get 5 out of those? Feature B is, do you have someone in your family with EDS? That's pretty straightforward, theoretically, assuming that someone in your family could actually get a diagnosis and found a doctor that they knew would make the diagnosis. But it's helpful if they know that. I'll often comment like, dad is super flexible, or, mom has these symptoms too. And then feature C is related to pain related to that. So like, so what if you're hypermobile? There's a benign hypermobility part of the spectrum that does not meet criteria for EDS, but some people are just flexible without a genetic mutation. So, is this functionally impairing you? Is it creating pain? Is it creating recurrent injuries? And it's not just, oh, I have some chronic shoulder pain because I had that old tennis injury. Is this affecting your whole body? So there's clinical criteria for that. And then lastly, like I mentioned, it's ruling out of other things. So I have patients who I absolutely think meet the criteria, probably have EDS, even without the genetic markers, if we haven't gotten that information. but they do not meet these criteria. And there's people who are just really, really flexible, but maybe they are barely meeting this criteria. Like there is a little bit of clinical discretion with this. And so why do doctors not just like follow this checklist? Why can't we just like give patients a diagnosis? Well, one is that I mentioned earlier, training is an issue. Because EDS is a connective tissue disease, it can infect the heart, the blood vessels, joints, skin, pelvic floor. It can impact lots of different parts of our bodies. There's not someone who like owns this disease. So for example, if you had a heart attack and had heart failure, clearly a cardiologist, a heart doctor is going to take care of you. But these are one of those diseases that impacts lots of different organ systems. So there's not like a primary EDS type of doctor. Certainly there are people who have become specialized in it and built centers of excellence around it, but there's not someone who really owns it. So that's one. The second is that I live in Atlanta, a city of 6 million people, and because of resources, even in a city with this many doctors, the academic center here will only see people with a vascular subtype of EDS because it's the most life-threatening. And so if you have all of the other symptoms for any of the other subtypes, like they're just not going to see you because they have to pay attention to the highest risk group of people. So even in a city like ours with lots of resources, you may still not have the resources to see those doctors. There is one other doctor in town who's historically done this testing for patients, but to get in, it costs money to see her, and there's a long, long wait to see her. And so there's folks like me who've kind of stepped into the space and are trying to help patients navigate. So it is really a problem. And in our healthcare system, unfortunately, when you're limited to a 10-minute time slot and you have a lot of symptoms and this whole exam to go through, often people feel like they're not qualified. Lastly, when it comes to genetics, ethically, if I'm going to run a genetic test on someone, I should, one, know about all the different things that may cause the symptoms that my patients are having. I should be able to counsel the patients on the limitations and benefits of this testing. I should be able to know the false positives and false negatives of this testing. And then on the back end, you're supposed to do post-test counseling. So you say to the patient, this is what the test results are, and this is what that means. And so I think a lot of us may not have gotten that genetics training. And so for all of these reasons, it is a huge barrier to patients to even find someone. So if you are lucky enough to live near anyone who specializes in EDS or a clinical center of excellence, absolutely go. Even without a diagnosis of EDS, you can still access services, physical therapy, pelvic floor physical therapy, pain control, and other comorbid illnesses like POTS and MCAS, which you've heard me talk about. But I'm not trying to paint a pretty picture. I understand it's really challenging, and I want you to understand why that's so hard. Lastly, I want to show you some pictures. And then we'll get you out of here. Share the screen. Oh my goodness. Right, I'll show you this stuff again. Okay, pictures. So that's the diagnostic criteria. I mentioned pysogenic papules. We know that most medical literature looks at people with not a lot of pigmentation in their skin, so they're often described as these yellow or flesh tone papules. I couldn't actually find someone with a lot of pigment in the pictures online. That is a problem with the healthcare. But anyway, there are these little lumps that you'll see along the heel line particularly. I talked about atrophic scarring earlier. So there's a scar that's here. You can tell it hasn't healed as a beautiful linear scar. It's gotten stretched out. And there's kind of some floppiness, some stretchiness of that scar. It's not like the perfect taut scar that you would see. So they call that atrophic scarring. And then lastly, here's a picture of that stretch test on the forearm to see if there's skin extensibility that you can see. Resources. So the Ehlers-Danlos nationwide organization at ehlers-danlos.com, Ehlers-Danlos.com is excellent. They have tons of education for patients and for clinicians. They go through these diagnostic criteria. It's an excellent resource if you're looking to try to find a clinician in your area. So please take a look at them. There's also podcast. Linda Bluestein's Bendy Bodies podcast is excellent. It really talks a lot about the associated conditions. I think she's great. And then if you have any questions, you have any suggestions for future topics, or you want to contact me to join the email list or make an appointment, this is where you can find me. The website's karapeppermd.com. And I appreciate you being here. Thanks so much.